My name is Rich Pratley. I'm the medical director for the Florida Hospital Diabetes Institute, and I'm joined on backstage by Dr. Jay Bornstein, who is also associated with Florida Hospital in the podiatry group and runs the residency practice here. So we're delighted that you're here. We do lectures on diabetes, different topics about diabetes from time to time. The idea is to educate you, give you opportunities to ask questions, and to interact a little bit with us in a way that you don't necessarily get to do in your 5 or 10 minute visit with your primary care docs. So we have some slides that we're going to show you, and we've kind of broken it out between the two of us. So I'm going to start off with a little discussion about why diabetes control is important. Jay's going to talk about what you have to do to protect your feet, and then I'm going to round it up by a little overview of what's in store for the future, both here at Florida Hospital and more generally in diabetes, because that always seems to be one of the questions that comes up. So, before I get started, a little housekeeping. Let me just finish with that. We have parking passes for you. If you're in the parking structure, you have a little goodie bag in front of you that has some information about Dr. Bornstein's practice, as well as our research group that does studies with diabetes. And up here, there's a handout on one of our cooking classes. These are free, and they're held obviously right here. So you're welcome to take one of those on the way out. So, I'm going to talk about improving blood sugar control. And invariably, when I talk to people, there are some certain questions that often come up. The first question with my patients is, well, what's a normal blood sugar anyway? The second is, you know, why is high blood sugar bad for me? I don't really feel bad. The third is often then, well, if high blood sugar is bad, what should my blood sugar be? And if I can get it down into a good range, will that help protect me from some of the complications of diabetes? And then, if getting it down is good, how can I get it down? And then finally, I always get questions about the importance of diet and exercise. So some of this is going to be some graphs, some things that I use when I talk to other doctors, but I'll try to go through it in a way that's that makes sense to everybody, including myself, which is not always the easiest thing. So just a little bit of an overview about the problem of diabetes. You may or may not be aware, but we're currently in the middle of an epidemic of diabetes. We have about 26 million people in the United States with diabetes, a little bit over 8% of the population. And every year, more than 1.5 million new cases of diabetes in this country alone. By 2030, we expect over 30 million people with diabetes. And part of the reason that we have so many cases of diabetes is because our population is getting a little bit older. There are more people at risk for diabetes, and of course our society has become overweight and we're not as active as we used to be. And all these things are risk factors for developing diabetes. Now, there are different kinds of diabetes. There's type 1 diabetes, which is what we used to call juvenile type of diabetes. And then there's all of the rest, which mostly we lump together as type 2 diabetes. The overwhelming majority of diabetes, more than 95%, is this type 2 diabetes. So this is the what's a normal blood sugar slide. And what I've shown you here is a scale that's kind of on the left hand here of blood sugars going up. And these are two different bars that indicate what blood sugars are. So normal blood sugar is less than 100 milligrams per deciliter in the morning when you get up before you've had breakfast. That's what we call the fasting blood sugar. After you eat, as some of you are doing now, or some of you did earlier today, your blood sugar normally goes up. But it doesn't normally go up much above 140. So anything below 100 fasting and 140 after a meal is considered normal. Now, diabetes starts if your blood sugar in the morning is above 126, or after a meal or a glucose tolerance test if it's above 200. And then there's a whole range of blood sugars in between that's here in the green. That's called either IFG or IGT. And these sort of represent pre-diabetes states. Not quite diabetes, but definitely not normal. These people are at high risk for going on to diabetes. So a normal blood sugar, 100 in the morning, less than 140 after a meal. People with diabetes somewhere above that. Now, just to put things into perspective, many of you probably have diabetes, but it's not unusual to have diabetes blood sugars in the 200s, 300s in people with diabetes. That's not good control, but that's oftentimes where people are. My own personal record is 1,400 for a blood sugar in a lady who was older and felt fine. What's that? 1,400, yeah. We also use a measure called the hemoglobin A1C. The A1C is an average of your blood sugar reading over about 3 months. And that's a different scale. It's a different number because it's a percentage. And the percentage there ranges from a normal of around 4.5 to 5.5 up to highs in the 15 to 17 range. So a normal A1C would be less than 5.5. There's a borderline range for that too, from 5.7 to 6.5. And then anything above 6.5 there is considered diagnostic of diabetes. And we'll talk about the importance of an A1C in just a few minutes. Now, we care about diabetes, of course, because of the high blood sugars, and if they're high enough, that can cause problems. But we also care about it because of the long-term complications of diabetes. And these include problems with the kidneys, the eyes, the nerves, and the vascular system, or the heart. So we can roughly divide these into the microvascular complications, that means the small vessel complications, and the macrovascular complications like the heart. In terms of the kidney, diabetes is the leading cause of kidney failure in adults. Almost 50,000 cases a year in 2006, and the majority of the new cases of diabetes were attributable to diabetes. It's also the leading cause of blindness in working age adults, somewhere between 12 and 24,000 cases of blindness in 2006. We'll talk more about the foot complications associated with diabetes, but this is significant as well. Somewhere between 60 to 70% of people with diabetes will have some form of nerve damage. They may or may not know it. And 2 to 4-fold higher risk of having heart disease if you have diabetes. And heart disease is the #1 killer among people with diabetes. So we really focus on controlling risk factors for heart disease in addition to blood sugar. Diabetes is also a very expensive disease. Somewhat over $200 billion per year is spent on caring for people with diabetes, medications, hospitalizations, and lost time from work. $200 billion used to sound like a lot of money until we went into that financial decline in 2008, and that looks like about enough money to bail out one bank or something. So it doesn't sound like so impressive a number, but it is a huge amount of the money that we expend on healthcare. So this slide simply illustrates that the higher your hemoglobin A1C, this average blood sugar reading, the higher your risk of developing all of the complications of diabetes. So in blue there is the eye damage or retinopathy, in yellow is the kidney damage or nephropathy, in green is the nerve damage, and this is also an indicator in red of kidney damage. So you can see along the bottom that the higher your A1C, the greater your risk for developing all of these microvascular complications of diabetes. The same is also true for heart disease. This is a myocardial infarction or heart attack, and it turns out that the higher your A1C, the higher your risk of having a heart attack. Now this all suggests that it would be good to get your A1C and your blood sugars as normal as possible. But in medicine, sometimes what makes sense doesn't always pan out. So we like to have what we call controlled trials in order to test these sorts of, sure, come on through. Let me start again. All right. This is the first study that demonstrated how important diabetes control was. This is called the Diabetes Control and Complications Trial. It's a trial in patients with type 1 diabetes. There were about 1,400 patients, mostly young patients, who were randomized, that is, assigned to either intensive glucose control or normal glucose control. And back then, back in the 70s and 80s, the intensive glucose control was trying to get an A1C down around 6 to 7, and the usual glucose control ended up around 9% for the A1C. This had a huge effect on lowering risk for retinopathy in your upper left-hand corner, kidney damage in your upper right-hand corner, and that's true for both people who had no disease to start off and people who had minimal disease to start off with. So the blue lines are the people who had better glucose control, and they had much less risk of complications. So that's type 1 diabetes. Does the same apply in type 2 diabetes? And the answer is yes. This is a Japanese study where they treated patients with type 2 diabetes with insulin to lower their blood sugars, and they also saw big reductions in risk for eye damage and kidney damage. Now, perhaps the best study of this is a large study called the UK Prospective Diabetes Study that was conducted in the United Kingdom. They took new patients with type 2 diabetes and they assigned them to either intensive glucose control or usual glucose control. And they followed them for now over 20 years. The main part of the trial released results at around 12 years. And what they found in this trial was, even though they only got about a 1% difference in hemoglobin A1C in this trial, that was enough to decrease your risk of microvascular disease by almost 40%. It decreased your risk of vascular disease in your legs by over 40%. It decreased your risk of myocardial infarctions, stroke, heart failure, and even eye damage such as cataracts. So this is other evidence that good glucose control is very important to controlling risks in diabetes. So where does this leave us? In general, what we think is that an A1C should be less than 7% for most people with diabetes. And this is consistent with all of these research studies, and it is something that we think that we can often achieve in clinical practice. Now, less than 7% is not normal, but the benefit from going from less than 7% to completely normal, like 5.5%, is relatively small. And the risks of complications goes up as you try to get lower and lower blood sugars. And so we've kind of settled on this number of less than 7% for most people. Now, that doesn't apply to everybody. Diabetes is very much an individual disease, and we need to target the A1C according to whether or not people are really going to benefit from lowering their blood sugars a lot. And there are some people, for instance, people with terminal cancer, where it really doesn't benefit them to have normal blood sugars. They have other things that they need to worry about. So we're not as aggressive in people like that. The other thing that we have learned from all of our studies is that it's just as important to control blood pressure and cholesterol as it is to control glucose. Remember I said that most people with diabetes die of heart disease. There's very good evidence that controlling blood pressure and cholesterol lowers risk for heart disease in patients with diabetes. And so when you go to your doctor, you'll focus on your blood sugars, but you'll also always get your blood pressure checked, and you should get your cholesterol checked regularly. And what we know from one of these studies is that if you do that, if you focus on lowering blood sugar, blood pressure, and cholesterol, getting everybody on the right medications, even very simple medications, that can reduce risk for all of these microvascular complications and dying by up to 50%. So it's a huge effect in terms of the things that we can do. So anybody know who this dog is? Mabel. Why am I showing you Mabel? So these two doctors are Banting and MacLeod. They were the first discoverers of insulin. And the way they found insulin was to test it in dogs. And Mabel is one of the first dogs that was treated with insulin. And she actually looks pretty healthy. This is one of the first children treated with insulin. Diabetes was a fatal disease back in the early 20s before we discovered insulin. And this is an example on the left-hand side of this young boy essentially wasting away because of diabetes, because we didn't have any good treatments. And on the right-hand side is him a couple of months after starting insulin therapy. He looks like a healthy boy. Isn't that amazing? That's the miracle of insulin. So that's where we started with diabetes treatments. And things have progressed over time. For many, many years, up until the 1950s, all we had was insulin. We got better at making insulin. We got it refined, and it became more pure and more concentrated. But basically, that's all we had. And then in the mid-50s, we developed drugs called sulfonylureas. Believe it or not, we still use those drugs and insulin today. Not a lot happened from the 70s until the 90s, but then really it was an explosion of development in drugs for the treatment of diabetes. We developed drugs called biguanides. This is metformin that almost everybody with type 2 diabetes uses nowadays. And then there was another class of drugs, the alpha-glucosidase inhibitors and insulin sensitizers, the glinides, we have GLP-1 receptor agonists, amylomimetics, DPP-4 inhibitors, and the list goes on and on. And there are probably at least as many new drugs in development that are not yet available in the clinic to treat diabetes. And so we have lots of tools to treat diabetes nowadays. Now, none of these tools are perfect, but they are a long stretch better than what we had even just 10 or 15 years ago. So the message is that there are lots of different ways to get your blood sugars to go. And if you're having problems with one medication, there's lots of alternatives. How about the role of diet and exercise? Many people think, well, I'm on medication. I don't really have to worry about what I eat anymore because the medication is going to control my blood sugar. And that's not actually the case. It turns out that even if we use insulin, people can eat enough to increase their blood sugar even when they're taking insulin. So it's important for people to get good education about diabetes and to learn proper nutrition skills. And this is actually a study that was done with diabetes education and nutrition education, meeting with a nutritionist. And what it showed was that at 3 months and 6 months, the reduction in hemoglobin A1C was almost as good as you get by starting a new medication, and cheaper, as it turns out, and probably better for you over the long run. This is data from a large National Institutes of Health sponsored study called the Look Ahead study. This is a long 15-year study in patients with type 2 diabetes. I have over 5,000 patients in this study. And the goal here is to help people lose weight to see if that improves their blood sugar control, as well as reduce complications of diabetes over the long term. Their first year data in this intervention, in the blue people who got the intensive lifestyle intervention, they were able to lower their body weight by about 9 kilograms. That's almost 20 pounds. And on the left-hand side, you can see that the A1C in blue went down by 0.6, 0.7%. Again, that is about as good as you can get with many medications. So there's no question that diet and lifestyle interventions, weight loss is really important in improving blood sugar control. Physical fitness is also important. It turns out that people who are more physically fit have a better mortality. They don't die as frequently as people who are not as physically fit. So exercise has a number of positive benefits. It improves the way insulin works in your body. It helps you lose weight. It makes you feel better, and it's better for your heart. And it helps you live longer. So on the left-hand side are the people who are the most physically active. The right-hand side are the people who are most physically active, and the left-hand side the people who are least physically active, and the people who are least physically active had the highest rates of death. So the bottom line message is that high blood sugars are associated with lots of long-term complications of diabetes. There's very good evidence that if we treat your diabetes and lower your blood sugar, you can prevent the risk of many of those complications. And we have now many ways to treat diabetes, many medications, but also, very importantly, diet and exercise. So I'm going to now turn it over to Jay. Jay is going to focus on the complications of the feet, and then we'll come back to me after that.
So we are going to jump to the feet, okay? And of course, the first question is how does diabetes affect my feet? Well, it affects your feet in three basic ways. And Rich alluded to that before, some of the secondary issues regarding diabetes. In the feet, we worry primarily about neuropathy, which manifests itself in a number of different ways, but basically put, your nerves don't function the way they're supposed to, okay? We worry about peripheral vascular disease. Again, blood doesn't get to your feet like we need it to. And that can all result in foot deformities. Foot deformities create pressure points. Pressure points create potential areas of breakdown in the skin. Potential areas of breakdown present us with issues regarding infection. Infection leads to a whole host of bad things that we don't want, right? So hopefully I'm going to give you some really simple ways to avoid being a statistic, all right? So when you put those three things together, I kind of alluded to it earlier, the neuropathy, peripheral vascular disease, and foot deformity, you put them all together and it greatly increases your chance of being one of those bad statistics. The people that the primary care physicians all scare you with, if you don't take care of your blood sugar and you don't take care of your feet, you're going to lose your limbs, okay? And it's a real issue. The good news is it's an issue that you don't have to deal with if you are attentive to your feet and you manage your diabetes. If you do that, there's no reason you should be one of those statistics, okay? So, sensory neuropathy. Basically, these are smaller nerve fibers and they can be affected one of a couple of ways. The jury's kind of out on exactly what causes this. Is it a metabolic issue? Is it a vascular issue? It's probably somewhere in the middle. You guys probably don't care about that. All you care about from this, your takeaway here is, when you have sensory neuropathy, it decreases your ability to feel things. You know, people think of pain as a bad thing, but quite frankly, it's not. Pain is your body's way of telling you to stop doing something. So when you're walking around, you know, the theme park in that bad pair of shoes and you get a blister and your foot hurts, you stop and you attend to it. And if you do that, it's generally a very simple, easily fixable problem. But when you have sensory neuropathy and you can't feel that warning, then you just keep going on and you go to Fantasyland and you go to Tomorrowland, and before you know it and you get home, you've got a little bit bigger problem than you had once thought of, okay? So, autonomic neuropathy. People don't necessarily think of this as a nerve-related issue, but autonomic neuropathy, as it applies to your feet, we concern ourselves with sweat production, oil production. And what does that do? That keeps your skin nice and supple and moist. When your feet get dry, the skin gets stiffer, the skin cracks. If the skin cracks, we now have a port of entry for bacteria. So that little crack in your skin can create an infection. Again, you might not know about it. If it's on the bottom of your feet and you're not paying attention and you've got some sensory neuropathy in combination with the autonomic neuropathy and you don't feel it, it can get way out ahead of you. And I can promise you that when we see people that come, unfortunately, to the hospital with diabetic infections and limbs that are at risk, almost always, if you sit down and you talk long enough and you really get down to what happened, it's usually a very small incident. It's something that didn't seem like anything at the time, okay? So, motor neuropathy. Well, among other things, diabetes can affect the motor fibers that control, for example, the very small, what are called intrinsic muscles in your feet. Your hands and your feet have big muscles and tendons that move the fingers and the toes and the hands and the legs. And it also has some smaller muscles that help stabilize things like your toes. Well, when those smaller intrinsic muscles get affected, the toes aren't as stable as they were before. So they buckle, they bend up. You've probably seen or maybe even have hammer toes and things like that. Well, when those toes buckle up like that, they put more pressure on the bottom of your feet, on the tops of the toes. So now we're back to that same thing again. We've got more pressure in an area where perhaps we don't have as good a sensation as we had hoped for. So now we've got another at-risk area. So this should be a review. Look at this. There's a lot of things that I think you just heard in the last lecture. What can you do to prevent neuropathy? Well, number one on the list is controlled diabetes. Where have I heard that before? That was the last lecture, wasn't it? I think you saw all of these things, and you're going to see these again. You're going to see a slide very similar to this again. And I'm going to tell you this. You need to learn this stuff. When you go to see, someone comes to my office, or I'm sure when they go to see Dr. Pratley or your primary care, I'm hoping that you're hearing a lecture for the 30 or 40 or 50th time, because so much of this is prevention, and so much of this is so easy to take care of on the front end and so difficult on the back end that it's worth having to have you listen to these things over and over and over again. Control your blood sugar. Keep your blood pressure in normal range. Exercise regularly, right? You have to be a little careful with exercising with your feet if you have sensory neuropathy or if you have peripheral vascular disease, because again, you're going to necessarily put more pressure on those areas, but that doesn't mean you can't do it. It just means that you have to be very aware of what you're doing, and it means that you have to pay attention to things like shoe gear and what types of activity you're doing. But I would argue that the benefit of exercise greatly outweighs that risk. As long as you're attentive, pay attention to it, you should be able to safely exercise. We can create a program that will get the job done and not put you at greater risk, okay? Ooh, there's one I haven't seen before. Stop smoking. Very good. We don't have to have that lecture, do we? You all have heard about smoking, right? It's not good for you, okay? And as you can see, the other things, eat a healthy diet, that sort of thing, and follow up with your primary care or your specialty providers, all right? Which brings us to peripheral vascular disease. Again, some of the same things that Dr. Pratley talked about before, okay? High blood pressure, poor diet, high triglycerides, high lipids, that sort of thing can create decreased blood flow. Why is that important? Well, if you have tissue that gets injured, you have to have blood flow to get it better. If you have a seemingly minor insult, a blister, a small wound on your foot, if we don't have a decent enough blood flow to heal this wound, we've got a real problem. If you get an infection, it doesn't matter how many antibiotics we give you if there's no blood flow to get to the site of the infection, okay? So it's critically important. How can you help improve blood flow? I'm glad you asked. Look, it's some of the same things again. So it looks like those few things, there's a lot of good that can come from that. And I don't know, do any of those look particularly difficult?
Yeah.
Oh, which one?
Maintain a healthy weight.
But you know what? Can you do the exercise?
Yeah.
Can you keep your blood sugar in good control?
Yeah.
The weight will come down.
It came down, but then it went back up.
Well, you can't give up. It's not like you do the exercise and stop. Okay, I've reached my target, I'm good. No, you got to keep doing it. Plus, I'm going to almost bet if you're out there exercising and you keep your blood sugar in good control, I don't know, you feel better? You feel like you got more energy?
Yeah.
Sounds like a good reason to do it. Okay, foot deformity. I'm not going to give you too many of these ugly slides, but this is the bad part. This is, we try to be nice to you and tell you all the good things. Sometimes we got to scare you just a little bit to maybe get your attention. Foot deformities, change in shape of the foot abnormal pressure points, and look what can happen. You can get that wound. Why is that important? Because you see these numbers here? This is the scary part, okay? Pay attention. 25% of all diabetics end up with wounds. Why are the wounds important? Well, you saw the numbers in Dr. Pratley's presentation before. 60%, more than 60% of the lower extremity amputations, non-traumatic amputations, are the result of issues dealing with diabetes. 85% of those started with an ulcer. Now, if we can prevent that ulcer, look what we can do. 5-year mortality rate. 5-year mortality rate. Now, I would argue that perhaps that's not solely due to the foot wound, because quite frankly, a lot of those people have other things going on. They have heart disease. They have other issues that they're dealing with. But that's a very scary number. Now, the good thing, see the bottom number, 45 to 85%? We can reduce that. We can reduce that by basically paying attention to your feet. How do you do that? What can I do? What can I do? Okay, let's start real easy. There we go again. Take care of your blood sugar. That's going to be on every list that we've got. Check your feet every day. Basically, you have to understand, neuropathy, peripheral vascular disease, it doesn't happen like you're turning a light switch on and off. It's not like Tuesday I was great, Wednesday, oh my goodness, I can't feel my feet. It's a very subtle thing. So you have to train yourself to be diligent about this and be vigilant. You have to pretend that you can't feel anything. So you have to use other senses, okay? And we'll get to that a little bit more in just a second. But basically you want to be looking at your feet every day. You want to be active. You want to be washing your feet, drying your feet, putting lotion on your feet, but not in between your toes, okay? We want to do that because of the autonomic neuropathy, right? We want to get moisture in there. We don't want our feet cracking, okay? Trim the toenails. If you can do it safely, leave them a little bit long so that we don't have to have ingrown toenails. If you have issues with that, if they're too thick, if you can't get to them, get someone else to treat them for you, okay? You don't need to get aggressive and get in there with the clippers and cut something and now we got a wound that we're dealing with, okay? Wear your shoes. Wear socks. Keep your feet warm. Keep them protected. I will tell you a very scary story. Happened to a patient of mine about a year ago. Profoundly neuropathic. For some reason, he didn't believe he was until he took the trip across the parking lot at a water park here. I won't name it. It was one of the large ones with the guy with the ears. And he ran out to the parking lot to get something, and he ran back, and he ran back out to go home and came in the next day. What happens to a black asphalt parking lot in Florida in August around 3 p.m.? Yeah, he had burnt the entire sole of both his feet. He had no clue until the next day when he woke up and he had huge blisters on the bottom of his feet. Okay? Wear shoes. Wear shoes. I know it's Florida. I know we don't like to do that, but you need to. You need to, because it's not worth a visit to the hospital. Okay? Well, by the way, look at the bottom. There's that no smoking thing again, okay? So, what is a diabetic foot examination? Basically, what you're supposed to do is this. Number one, look at them every day. You know what I'm thinking? We talked about washing your feet every day, putting the lotion on. That would be a really good time to do that, okay? Because we want to do it at the same time every day, okay? Because she's pointing at you. Uh-oh. I'll talk directly to you then. Okay. You want to do this the same time every day because we're looking at changes. Okay. The reality is that if you look at your feet in the morning on Monday and then you look at them Tuesday evening, well, you may be one of those people whose feet swell by the end of the day. And that may be very alarming to you when maybe it's not a big deal. Okay. So you want to do it, excuse me, at the same time every day. And you want to have a well-lit area. And if you can't see the bottom of your feet, they make these really handy things, mirrors, okay? You put them on the ground and look at the bottom of your feet because that's arguably the most critical part to look at. That's the thing that's beating the ground. That's the thing you can't see. So you want to make sure that you inspect them every single day. All right?
I have a question.
Yes.
Okay, I want to know your opinion about Crocs and about the shoes that look like
Feet.
natural feet, the toes. Are those safe?
Crocs are better than barefoot. Okay, if they're well fitted, they're fine within reason. I don't think I would try to walk, long distances in the Crocs because they don't really give you a whole lot of protection. And the little toes with the feet, for a diabetic, I would argue they're probably not the greatest shoes you can have. They don't provide as much protection.
Is there any certain type of brand like New Balance?
Oh, we can talk for hours about that. You and I will talk about that later,
I
okay?
have a question too. The exercise.
Yes?
I have plantar fasciitis, and my exercise is the treadmill. And I asked my cardiologist, can the treadmill cause it? And he said yes, but
Well,
I
he's
haven't
right.
given up.
Well, don't. We'll talk. We're going to do a little screening for folks that are interested afterwards. And we've got some folks here, and we'll take a lot of time and discuss all those things with you, okay? So, what are you looking for? In a word, change. We're looking for something that looks different today than it did yesterday, okay? We're looking at changes in temperature. We're looking at swelling. We're looking at breaks in the skin. We're looking at discoloration and calluses. Just so you know, if you have a callus, it shouldn't have a little dark black or red spot in the center. That's not good. That's typically indicative of bleeding underneath a callus. And if that bleeding occurs, it builds up pressure. If it can't rupture through the top of the callus, it pushes its way deeper. And unfortunately, too many times when we see that and you pare that away, we've got a pretty good sized wound underneath. So you don't want to see that, okay? And of course, the obvious things. You're looking for breaks in the skin, anything that hurts. So in a word, change. If it looks different than yesterday, and we're doing the exam at basically the same time, change is probably something you should be concerned about. And I would tell you this, if you see anything that you're not sure of, pick up the phone and call. In my office, our diabetics understand, and my staff, more importantly, understands. If you're doing your diabetic foot exam and you see something and you're like, I don't know if that's a big deal or not, pick up the phone and call. We're going to get you in there. And here's a secret. When it comes to this, I'm kind of lazy. I would prefer to see you for something very small and insignificant and tell you that than for you to wait a week, show up in my office, and now you're infected. I've got to put you in the hospital. I've got to come visit you. I've got to take you to surgery. That's way too much work. I'd rather see you come in when it's simple, okay? You don't want to go to the hospital, and neither do I, okay? So you come in, and you get it evaluated. So, again, same type things we were talking about, basically changes, redness, numbness, that sort of thing. So I guess the next question is, well, how often do I come in? Because you need to see somebody, all right? So essentially, they've got a handy-dandy risk scale. And it goes from no neuropathy, no deformity, no peripheral vascular disease, which is the lowest level of risk, to all the way down at the bottom, which is a foot that's already got a wound or an infection, what have you. And based on those things, you have an idea of how frequently you should be seen. At a minimum, if you're diabetic, you need to have somebody looking at your feet at least once a year. At least. That's if you can feel everything and your blood sugar's great, because again, those things just don't change like flipping a light switch on and off. So you need to be evaluated. You can read down there. Those are going to probably mean nothing to you, but those are the things that you learn on an initial visit when you see a diabetic and you assess the risk and you put them hopefully on a schedule that will keep them from becoming that really, really bad statistic. So, little problems turn into big problems. That's the last scary one, okay? No one wants this. This is just not good. This is what it looked like. A nail in a shoe that they didn't see. Okay? And I hate to tell you, but that's actually a very good outcome. We changed it. You can start looking again. Don't worry. So here we go. Wow. How many times have you heard this already? Very good. Just memorize that and you'll be okay. All right? Now Dr. Pratley is going to tell you about some new drugs. All right?
Thanks, Jay. So what he said is absolutely true. My lady with the blood sugar of 1400, we got her blood sugar under control, and I followed her for several years, and she came to see me one day and she swore, oh yeah, I can feel fine. And I always have people take their shoes off, and I always look at their feet, even if I'm seeing them every 3 months. And I said, well, do you ever go around barefoot in the house? Never. I said, maybe you could explain how you have a tack in the bottom of your foot. And I pulled a tack out of the bottom of her foot. Didn't cause any problems for her, because it was a little tiny one. But it was very clear that she couldn't feel, and she was running around without shoes. And it could have been a very bad outcome. It could have been like the nail in the shoe and the surgery that had to result from that. So many of you may not realize that Jay is actually very famous. He's a foot doctor to Dancing with the Stars, isn't it? So I had a patient, or I heard about a patient actually, that Jay was taking to surgery. And he's all on the stretcher there, about to go under anesthesia, and he looks up at Jay and says, Doc, will I be able to dance after my surgery? Jay's a very good surgeon. He says, yeah, I don't see why not. And the patient says, well, that's great, because I can't dance now. So, question is, yeah.
If you already have the numbness or the discoloration, can it be reversed, or is it just not going to get any worse?
So it depends a little bit on how bad your blood sugar is, how long you've had diabetes, and how well we can control your blood sugars. So people who have new onset diabetes, whose blood sugars have been high, but been high for only maybe a few months or so, they often have some return of their sensation with better blood sugar control. And so I like to think of those nerves as being kind of stunned, but they recover. On the other hand, when people have had diabetes for many, many years, and their feet and their blood sugars haven't been well controlled, and their feet get progressively numb, that usually doesn't get better even with good diabetes control. I will say that I had a patient with type 1 diabetes who'd had diabetes for 55 years. He was a dentist, took pretty good care of himself. He had no retinopathy, got checked every year. He had no heart disease, got an exercise test every year. He had no kidney damage. I checked his urine every year. And he had feet like a baby. He got a pedicure every couple of weeks, which was a little excessive, but he had great feet. And that was because he'd managed his blood sugar and all of the other risk factors over the years. So, I want to end up with kind of a discussion about what are we doing about diabetes. Our mission here at the Florida Hospital Diabetes Institute is really to improve the lives of people with diabetes by promoting a healthy lifestyle, delivering very good quality care, conducting education for both patients and professionals, and also doing research that we hope in the long term will lead to diabetes prevention and a cure. And our goal is really to become one of the best diabetes centers in the world. These are some of the docs that we have here. You may go to one of them. Our education program is comprehensive. It's the largest one in mid-Florida. It's actually one of the largest ones in the whole country. We have group classes, we have individual counseling, nutrition counseling, we have counseling for women who are pregnant, we have training for people who want to go on an insulin pump, and we actually offer classes at most of the campuses. You're here in our demonstration kitchen. We moved in here about 18 months ago from our old site. And we built this education room specifically with the purpose of being able to hold classes like this. So today there was a group class with maybe 30 people in it, but also to do cooking demonstrations where people can see how you can cook healthy. And if you want to take one of these flyers, we have a program coming up in May on cool meals for the warm months. And so one of our nutritionists, Michelle Jakim, will walk you through this. And the cool thing is that cooktop there in front, has a TV camera, so you can actually see what she's cooking. It's just like being on the cooking channel TV. So if you get a chance, come take part in one of our cooking classes. So you'll see, you can participate in the class, you make meals, and you actually get a chance to sample what's made. So that's pretty cool. The other thing that we're doing has to do with developing new treatments for diabetes, and this is a partnership with the Sanford Burnham Institute. The Burnham Institute is now out at Medical City over by Lake Nona, and this is kind of what it looks like from the aerial view. It's a large lab that's focused on new treatments for diabetes, obesity, and heart disease, so it's perfectly aligned with what we want to do. The Burnham Institute and Florida Hospital have gotten together to create what's called our Translational Research Institute. Translational research has nothing to do with translating things into Spanish and English. What it really means is taking discoveries from the laboratory and turning them into meaningful treatments for patients. And we've got a picture of the Grand Canyon there because it's a pretty wide gap at the moment. It takes years to do that sort of translation, and our goal is to shrink that time and to improve the throughput of for new drugs. This is our new Translational Research Institute. You may have passed it on the way in. It's on Princeton Avenue. We opened about 3 weeks ago. And it's a really cool building. I want to take you through a little virtual tour. This is an area where we do research studies, so it's got a nice waiting room and some exam rooms and some really cool toys. In the outpatient area, there's a DEXA scanner, which we can use to measure your bone density, but also how much body fat you have. And that's really important for some of our metabolic studies. And we can measure down to the few grams of fat in your body. The other thing that looks like a big donut is not a Krispy Kreme, actually. It is a MR scanner, a magnetic resonance imaging scanner. And it is a special one that's much stronger than the ones that they use for normal scanning and looking at things. This is one that allows us to detect how your muscles are functioning, how well they are metabolizing things through really special techniques that are done in 2 places in the world. This is one of them. This is them loading this scanner off the truck. It's a huge magnet, essentially, and they had to tear out a wall to put that in. We also have a clinical research unit where people come in and stay overnight, or even sometimes longer, and we have some really comfortable rooms, nothing like a hotel room. Waiting area, and it's really light and kind of a friendly looking place. Of course, if you're going to have people overnight, you have to be able to feed them, so we have a complete kitchen over there that will prepare food for the patients, and it allows us to actually test the effects of different diets. So we're really interested in the effects of different kinds of diets on glucose control and metabolism, and the people who work in the kitchen can toss together these special diets and know exactly what people are eating. There's another really cool technology that we have there. This is kind of an aerial view of one of the areas of on the second floor of the building, and it contains little kind of like dorm rooms that people will stay in for 24 hours, and in these dorm rooms we can measure energy expenditure. That is how many calories you burn over 24 hours. The rooms are big enough for a bed, a toilet, a treadmill, or a bicycle, and we can measure your energy expenditure when you sleep, when you're awake, when you're riding on a bike, and even when you're eating. It's one of the very basic metabolic techniques in the world for measuring energy expenditure and metabolism. There are 16 of these rooms in the United States. We have now 4 of them, or 25% of the capacity in the entire country. That's pretty cool. And there's an instrument rack that all of these rooms feed into, and it measures the oxygen and the carbon dioxide really precisely. It's really cool. The only thing that is lacking that I asked them to put in is that huge switch on the wall. You ever seen the horror movies where the guy throws a big switch and there's sparks and things like that? It looks like it needs one of those switches, and it doesn't have one yet. So we're also studying new approaches to treatment, and I've been involved with the development of a number of drugs. And as an example, one of the drugs that has been approved lately for the treatment of diabetes is a once-weekly injection. So people will take this medication and it will replace 14 injections or maybe 7 injections of different kinds of medications. And it turns out this is a pretty effective way to treat type 2 diabetes. And unlike many of our treatments, it doesn't cause weight gain, it causes weight loss. Hold up. What's that? Sorry. Oh, no, no problem. So that's pretty cool. That's one of the new developments. Now we have another product that we have studied in the lab, which is a different kind of injection, also once weekly. And one of the new studies that we have coming up uses this. This looks like a little pin. It's about the size of a match, and that's implanted right under the skin around the tummy, and it slowly releases medication. This is kind of a blown up schematic of how this works. And it releases basically the same kind of medication as is in one of those injections, but you only need to change this thing every 6 months. So you can take your medication and get this thing put in every 6 months and have good blood sugar control and a little weight loss. That's pretty exciting for us. We have a lot of things that we routinely use in the clinic. Insulin pump. Yep.
Does that would that take the place of a insulin pump?
No, because that actually, it's not releasing insulin, it's releasing another medication. But I was going to talk to you about insulin pumps. This is an example of a pump that we use now. Mainly we use them for patients with type 1 diabetes, but the latest version of these pumps not only releases insulin under the skin, but it can also sense your blood sugar levels over 24 hours. And it gives you warnings if your blood sugar is going up or going down, and it allows you to adjust the rate of the insulin flow. And that's all done with this little tiny plastic sensor and tube that sits underneath the skin. So you put that in, and that's good for 3 days. This is another example of an insulin pump. This one actually sits on the skin. It's sticky, and it has a little tiny needle in it, and then you work it with something like your iPad or iPod, and you can control it. You can control how much insulin you use with that. This is the latest in the insulin pump devices. This is a pump that's designed for patients with type 2 diabetes. You put it on, it gives you a basal rate, and you can take insulin doses with every meal. And then after 24 hours, you take it off and throw it away and put a new one on. Pretty cool stuff.
Is it out now, or?
All of those things I just showed you are out now. The only thing that's not available is this every 6-month thing. We're just starting to do clinical trials with that. So I just thought I would kind of highlight some of the things that are on the horizon that we think are kind of exciting for the treatment of diabetes. And again, our goal is to really change the face of diabetes here in Orlando and elsewhere.